go ahead, Marcus. You can introduce the first speaker.
Okay, thank you. So good morning, everybody, to this next session, which is focusing on innovations in technology in thoracic surgery. So we're going to hear 4 presentations looking at some of the newer technologies in thoracic surgery. So things like advanced VATS techniques, the use of robotic surgery, and the use of mechanical circulatory support and ECMO in thoracic surgery, and advanced imaging techniques used in thoracic surgery. So we've got a range of speakers presenting on these topics. So hopefully it will be an interesting and informative session. So to start with, the first presentation is from Benjamin Waterhouse, who is an ST5 national trainee in thoracic surgery, currently working in Middlesbrough, and he's going to talk to us about uniportal VATS.
Registrar working at James Cook University Hospital in Middlesbrough, and today I've been asked to present to you the evidence comparing conventional to uniportal VATS. I've got no conflicts of interest to declare, and just a bit about my background. So I've worked in 4 different thoracic centres across the UK, and in 2 of those there was at least 1 surgeon performing uniportal VATS, and so I've had the opportunity to see how things are done in different centres. So my aims and objectives: I'm going to give a brief overview of the history of VATS and its evolution. I'm going to give some consideration to the current spectrum of approaches that fall under the umbrella of video-assisted thoracoscopic surgery, clarify some definitions, and then we'll delve into the current evidence comparing conventional to uniportal VATS. And I've decided to focus on 4 different domains: safety, oncological outcomes, training and technical aspects, and patient recovery. So it's my intention to talk specifically about anatomical resections, and in particular lobectomies, performed by the different techniques, rather than more minor or more complex procedures, just to make it a little bit easier to make some sensible comparisons and draw some reasonable conclusions. So if we go back to the beginning, the first VATS lobectomy was described in 1992, and until 2006, fewer than 10% of lobectomies for primary lung cancer in the UK were performed by VATS. By 2015, this had increased to 40%, so a relatively significant increase. And the first descriptions of uniportal surgery were for diagnostic wedge procedures, and they were performed in 2000 to 2002. A large series of mostly 2-port VATS lobectomy was described in 2006, but the first uniportal lobectomy was performed in 2010, and there's the case report with a very familiar name connected to it. So if we start to look at the spectrum of how lobectomies are performed, we've got the uniportal, 2-port VATS, 3-port VATS, and just some schematics there of example port placements. But there's an obvious elephant in the room. So robot-assisted surgery uses 4 ports, or 5 if you have an assistant port. And so we've got different people who've got very different views of what the future holds. And is the future about having more or fewer holes? So then at the other end of the spectrum, we've got natural orifice lung resection. So maybe I'm quite naive, but I'd never really considered the umbilic as an orifice, but that might just be me. The key feature here is obviously the avoidance of an incision that will cause neuropraxia of an intercostal nerve, but it also shares that property with subxiphoid or subcostal uniportal approaches. I am fairly certain the abdominal surgeons would consider an umbilical approach a port, but the point I'm trying to make here is that there's always going to be someone who's trying to push the boundaries. But you can see here that you can make your way into the chest and perform a lobectomy through the umbilicus. So then if we take a look at our extended spectrum, we've got the natural orifice surgery down at one end. I did consider putting SABRE or navigational bronchoscopy ablation as 0 ports, but I had to draw a line somewhere. And then we've got the robotic surgery down the other end. And so the really are a wide range of options of minimally invasive thoracic surgery. Sort of to blur a few lines, we've got plenty of people who would perhaps do 3 ports for a lobectomy, but a uniportal perfectly acceptable for a minor procedure or for a wedge. And then within the uniportal, we've got subxiphoid, transcervical or subcostal incisions. But for the majority of this presentation, I'm going to be focusing on uniportal through a single intercostal incision, or conventional 3-port VATS. So now for some definitions. So what do we mean by conventional VATS? For simplicity, I'm including any multi-portal approach with 2 or more incisions. This is most commonly a 3-port technique. And most of the examples are an anterior approach, but there are some advocates of posterior VATS. So here are some examples of port placements based on people that I have worked with. I'm actually quite glad this is a pre-recorded presentation, because this way I don't have to see the angry faces in the crowd for when I describe conventional VATS that doesn't reflect what they would do. But generally speaking, this consists of an anterior utility incision, for which most of the technical aspects of the procedure are performed, a posterior retraction port, and then the camera somewhere lower down, and for the people that I've worked for, that's most typically been the 8th intercostal space. So now to have a little bit of a think about what we mean by uniportal VATS, because not everyone is necessarily thinking the same thing when they hear that phrase, and make sure that we're all working from the same definitions. So the European Society of Thoracic Surgeons published a position statement from the uniportal VATS interest group in 2019, and so let's take a look at that position statement to see what different surgeons mean when they're using the term uniportal VATS. So we're talking about a single intercostal incision, so we're not including the subxiphoid and subcostal approaches here, up to a 4 cm incision with a soft tissue retractor such as an Alexis, but not with intercostal retraction. And so you can see here that about 70% are talking at less than 4 cm or a 4 cm incision, 8% are talking about an anterior incision, and 70% are using a 10mm camera still, even with the smaller hole. And you can see that 100% are using a skin retractor, and the vast majority are using the same incision for their drain. So here's an example of a uniportal incision in the 5th space in the anterior axillary line. And we can see that all of the instruments are going through the same port, as is the camera, and working in parallel. I have on occasion seen uniportal surgeons make their drain incision a little bit earlier in the procedure than they might otherwise, and a stapler may happen to slip through this incision when it's convenient, and it's hard to say whether this will appear on the operation note as a port or not, but there's always some room for blurred lines. And you can see a picture of how this works in practice with the camera at the apex of the incision. So before we consider the data in too much detail, let's take a look at some opinions. So these are all screenshots from papers about uniportal VATS, just to give us a bit of a snapshot about what the surgical community are thinking. So it didn't take me very long to assemble a collection of fairly bold statements presented without references or supporting evidence, and it just demonstrates how there are quite clearly strong opinions on both sides of this argument. So the proponents say that uniportal VATS is a new era in lung cancer surgery. Due to the single intercostal space involved in uniportal VATS, it results in less post-operative pain. It seems to have a rather short learning curve. That uniportal VATS is more ergonomic and enables surgeons to have more natural hand-eye coordination. It's associated with a shorter post-operative hospital stay and has better cosmetic results. So some fairly big claims there. But on the other hand, the opponents say that the crowding of the scope and the instruments inevitably leads to compromised dexterity. It puts patient safety at risk. It's more challenging than conventional VATS approaches. That there's not yet good clinical evidence. That spreading rather than incision length is the culprit for post-thoracotomy pain, therefore having multiple incisions is not important, and that the adequacy of oncological clearance is yet to be proven. So people clearly have got some ideas about whether they think this is a good idea or not, and we'll see if we can put any evidence to support one side over the other. So the questions that matter: is it safe? Is it oncologically sound? Is it for every surgeon? Is it for every patient? And is it for every resection? And ultimately, do patients get better faster? Do they have less pain? Just to frame our discussions, I think it's worth taking a step back and thinking about the differences between thoracotomy and VATS, just to give us a bit of context of thinking about the magnitude of difference we might expect between conventional and uniportal VATS. It seems reasonable to assume that the differences between conventional and uniportal VATS are not going to be substantially larger than those between VATS in general and a thoracotomy. And so we'll take a little bit of a look at the available results of the Violet study. So this was comparing VATS to thoracotomy for lobectomy, and it was using 1 to 4 ports in the VATS arm. The conversion rate was about 6%. In hospital mortality, it was about 1.4%. The R0 resection rate was very good in both arms. The length of stay was 4 versus 5 days in the VATS arm, and the pain score on day 2 was 3 compared to 4 in the thoracotomy arm. So some differences there, but they're not dramatic. So just give us a bit of a flavour of what we might expect. So I've been quite fortunate that 2 meta-analyses have been published in the last 6 months, and both of these are since the ASTS position statement. These are both primarily meta-analyses of retrospective, non-randomised cohort studies, with all of the biases that one might expect to go along with those. Often these are studies that use the centre's own historical series as a control group, so they've introduced uniportal VATS as a new technique, and then they're comparing their own historical conventional VATS results. And this means that the uniportal group is often going to have the benefit of more modern approaches to anaesthesia, to ERAS, to stapling devices, and those sorts of things. On the other hand, you might expect the uniportal group to be suffering from a little bit of a learning curve effect. So if we're being cynical, we might predict that maybe these results are going to show us that there's going to be better pain and length of stay for the uniportal group because of those advances, but with perhaps longer operative times because of the learning curve effect. So both these meta-analyses have been published recently. They each have 20 studies included in them, but they're not the same 20 studies. And there's 1 randomised trial in the top one and 2 in the other. They've each got over 4,000 patients. But one of them concludes equivalence and the other one concludes superiority. And so we'll dip in and out of these 2 meta-analyses as we go through our criteria that we outlined before. As I've raised some concerns about the retrospective nature of some of these studies, if we just have a look at the funnel plots, actually they're relatively symmetrical, so we've not got strong evidence of publication bias that's driving the results in these studies. The 2 randomised controlled trials, as there are only 2 of them, I think it's worth just mentioning them. Each had about 100 patients in with 1-to-1 randomisation. So how do we compare these 2 techniques? So I've already outlined the 4 domains. So in safety, we've got concepts such as mortality, conversion rate, and blood loss. Then we've got the oncological outcomes. So typically that's the 5-year mortality, recurrence rates. And you can also think about the quality of lymphadenectomy and then the resection margins on the final histology. Technical aspects, so this will include the learning curve, the suitability of the operation for all surgeons, the operative time and the time with a chest drain after the procedure and air leak, and then the recovery, the length of stay, pain, complications, and then quality of life, the things that are important to the patient. So if we start with safety, this is the 30-day mortality taken from our first meta-analysis. You can see that this was an outcome measure in 12 of the papers, and there was no significant difference between the 2 groups. So next we'll look at conversion rate, and so this is a forest plot taken from that same meta-analysis, and you can see that the diamond crosses the line of no effect. So similarly, looking at blood loss, we can see there's no significant difference between the 2 groups. So looking at our safety outcomes, we've got no clear evidence of any difference between conventional and uniportal VATS. So moving on to our oncological outcomes, so obviously I'd like to be talking about the 5-year mortality. Unfortunately, that's not available in the data that we have here, so we're going to settle for the 3-year mortality. And you can see, once again, there's no significant difference between the 2 groups. So now looking at the quality of lymphadenectomy, this obviously has the advantage of being immediately available with a post-operative histology. You don't have to wait 5 years to get these results, but it is still a surrogate marker for the quality of oncological resection. So you can see here that there is no difference between the number of lymph nodes removed between the 2 groups. Interestingly, our lab doesn't provide us with this number, but the pathologists in this study actually counted the number of individual nodes within the en-bloc nodal stations sent to them. And just for a bit of context, you can see here in this chart the number of nodes within each N2 station. So now if we take a look at resection margin, so this is another immediately available oncological outcome, which will give you an idea of how the patient might do in the longer term. Still a surrogate marker, but although it's quite interesting to know about, neither of the large meta-analyses presented data on this. One of the larger series did give us a little bit of data, which we can just discuss here. And so if we take a look at the residual tumour condition, as they refer to it, now we've got the 2 arms here, but actually the the in brackets refers to the percentage that were uniportal. So if I write in the actual percentage of R1 resection margins for each group, so 2% for the uniportal, 2.9 for the conventional, with no significant difference between the two. So looking at our oncological outcomes, we've not yet got any data that suggests inferiority or superiority of either group. Moving on to the technical aspects, so thinking about the learning curve. So I'm going back to that ESTS position statement, and this is different surgeons' opinions on what the learning curve is. And so most surgeons believe that the learning curve for uniportal VATS is less than 50 cases or less, which isn't too bad. Now looking at which patients will be suitable for a uniportal lobectomy. So if we look at the data from the ESTS position statement, you can see that there are definitely those who believe that larger tumours would be an indication for an alternative approach, but similarly with nodal status, if you've got evidence of N1 nodes on scan, then that might be an indication for a different approach to lobectomy. But there are still those who don't see these as being a contraindication for uniportal lobectomy. And once you start thinking about more complicated procedures, so it looks like around 1 in 3 would see a bronchovascular sleeve as an indication to convert to a multiportal VATS. And similarly, there are those who would see some of these procedures as an indication to convert to thoracotomy. So now looking at the operative time, so despite the fact that many of these studies will have suffered from a little bit of a learning curve effect, actually there's no significant difference between the operative time in the uniportal and the conventional VATS approaches. If we look at the time the patient spends with a drain, there's a very definite trend towards a less time with the drain in the uniportal arm, but the diamond does cross the line of no effect, and this does not meet statistical significance. However, now for the first time looking at the other meta-analysis, you'll appreciate by looking at the x-axis here why I've not been using this very much, because it's very difficult to interpret. But if I artificially stretch their figure so you can maybe see where the lines are, you can see that in their 20 studies that they looked at, the time of the drain was significantly lower in the uniportal arm. And so there's the p-value. So now thinking about other aspects of the patient recovery. So this is hospital length of stay. Once again, you can see that the diamond is drifting towards favouring the uniportal arm, but doesn't quite meet significance. However, if we look at the other study, we can see that actually this does cross that line, and there's statistically lower length of stay in the uniportal arm. So pain is obviously an important outcome from the patient's perspective, and so this is looking at post-operative day 1. And we can see here that again, there's a slight trend, but this doesn't meet statistical significance. And this is taken from one of the randomized controlled trials, just to break this down a little bit more. And we can see, looking at the pain score on a visual analog scale for the first 3 days was no significance, and similarly looking at the amount of morphine the patients were using, there was no significant difference between the two groups. So now looking at complications, and we'll do this in some broad groups. So looking at arrhythmia, you can see that there's no statistically significant difference between the two groups. Similarly, looking at respiratory complications, there is no overall effect for uniportal. And looking at other complications that aren't arrhythmia or respiratory, and again, it looks like there's a trend towards fewer complications in the uniportal arm, but doesn't meet significance. However, when you look at all complications, all bundled into one, this does meet statistical significance in this meta-analysis. So finally, quality of life is obviously a very important outcome measure to patients. This is taken from one of the randomized controlled trials. The body of the text actually suggests that these are mislabeled, so the uniportal group is actually the control group and the conventional VATS is the observation group. So this is a standard SF36, so higher scores are better quality of life, and you can see that the scores were generally higher in the uniportal group. Also, when they looked at lung function, this was also generally better in the uniportal group. So in summary, if we look at our 4 domains, Safety, multiple VATS has been around for 20 years, uniportal VATS for 10 years, and both seem to have excellent safety records. In terms of oncology, the short-term oncological operative markers look equivalent. We've not got the long-term outcome data yet to comment on that 5-year survival. Technical aspects appear to be equivalent, with a learning curve that's generally considered to be acceptable. Patient recovery is at least as good as with conventional VATs. Despite what the enthusiasts are saying, I don't think we've yet got convincing data that uniportal is superior. However, in the latter of the two meta-analyses, we did have a signal for perhaps an improvement in length of stay and length of time with a drain. So if we look finally back at that ESTS position statement, which concludes that uniportal VATs is an alternative to other approaches, but further follow-up and randomized studies will be required so that we can clarify some of these issues. So there's a bibliography. You can obviously pause that if you want to look through it in any more detail. And I'd be delighted to answer any questions.
Hi, Marcus. We are now going to run a brief poll, and the poll is going to be open for about 30 seconds to the audience, and they will be able to answer to this poll through their attendee view, as it is right now. So I can see the poll, and I can see the answers coming through. We're going to wait a few seconds. We got request in one of the chats that we were closing the polls too quickly. Thank you to the audience for their feedback. And Marcus, you can now introduce the next speaker.
Okay, thank you. So the next speaker that we're going to introduce for this session is Joel Dunning. Now, Joel was supposed to be on the panel this morning as a co-chair along with myself and Benjamin, but unfortunately he's otherwise engaged, but we still have his pre-recorded presentation. Now, for those of you that aren't aware, Joel Dunning is a consultant thoracic surgeon working up in Middlesbrough, who's always been at the front of innovation and development in thoracic surgery. Things like robotic surgery, uniportal surgery, microlobectomy, and lots of other technological advancements in the fields of thoracic surgery in the last 10, 20 years. So we'll move swiftly on to his presentation, which is going to be on the use of robotic thoracic surgery.
Hello, my name's Joel Dunning. I'm going to talk about thoracic surgery robotics. Isn't it crazy to think that in 2012, only 5% of people were having minimally invasive surgery, having this mutilating, huge thoracic surgery? Well, we've come a long way since then. But just before we dive into robotic surgery, let's just consider what is robotic surgery, because this is maybe not robotic surgery, but here I am with a wristed instrument with an automated camera holder that I control from my head. And I've got wristed instrumentation. I can do good suturing. I can control my own camera. So what are the benefits of robotics? So there are other instruments. There are instruments like this, artisanal wristed instruments. You can put them in both hands. And again, you can have a controlled camera holder, you can have these. So what are the benefits of robotic surgery? There's just a little something for you to think about. Why is it better to spend £1.9 million than something like this, which costs £1,000? We'll talk about that at the end. So the reason I question this is because there is an absolute tidal wave of robots coming to us. Intuitive have been very lucky because they've had 15 years of a complete monopoly. And yet that monopoly is about to be broken to pieces. So Hugo by Medtronic is coming soon. They're going to have a full suite of all these instruments, all their Covidien instruments, energy devices, the stapler, all coming very soon. Now, when I say soon, they've been saying they've been coming for the last 3 years. And again, they still say next year. So who knows when they're going to arrive, but it is going to be very soon. And Verb Surgical equally is the Johnson & Johnson serving of a robot. I talked to them a couple of months ago, and again, soon, 2022, they think. But the robot arms might be coming out of the table, so you won't have all these big, huge stacks to carry around your hospital. That might be very innovative. And they've got loads of other ideas about enhanced visualization, connectivity, basically putting everything onto YouTube because they're a YouTube company, and even using Google Translate to translate your telementoring into different languages. Exciting, futuristic stuff. There's more stuff in the future. The single port robot by Intuitive is just about to get an FDA indication for thoracic surgery. And it's going to be, I think, a massive game changer. You could put this subxiphoid into a patient, and certainly thymectomy is going to be the way to do it, subxiphoid uniportal. And I think very quickly it will go into lobectomy as well. These are really, really amazing instruments, brand new. And I've actually done a lobectomy on a cadaver, and it's phenomenal, better than any other lobectomy I'd ever done. But we are in the new era now of novel robots. We have effectively the first competitor to the Intuitive robot. It's the Cambridge Medical Robot, a brand new startup, started only 7 years ago in Cambridge by Mark Slack and 3 other pals, and now is the 3rd biggest medical device company in Britain. It's got a modular design, it's got all these instruments, it doesn't have a stapler, but it's got everything you really need. This is the robot in action in a cadaveric lab in the Evelyn Centre in Cambridge. And as you can see, it's very different to the Intuitive device or many other devices, because the Intuitive holds your instruments a bit like a pen and moves it like a pen, whereas this device holds your instruments like a lance or like a sword, which is a little bit different. But the advantage of that is that it's smaller, it's more modular, and it has more space for an assistant. The other thing they did very differently was the hand controls. Did you know that the Intuitive hand controls were designed by cardiac surgeons? The cardiac surgeons said they'd like these controls to be like their Castros. So they'd like their fingers to be doing the opening and closing. But Cambridge Medical Robotics said, that's so crazy. You've just taken your 2 most important fingers out of the equation, getting rid of your thumb, basically. But look here, if you use these fingers to open and close, you've suddenly got your best digit for doing a whole load of other things. So controlling a joystick, pressing the energy things. And if you've got your thumb suddenly doing things, you don't need your feet. So what you can then do is you can get rid of your foot controls. That means you can stand up if you like. And if you stand up, then you can get closer to the patient. Now, you might think, well, what's the point of standing up? But here I am, scrubbed. Of note, just have a look at the assistant. Look how much space he's got. And there's a lot less crushing in a CMR robotic thoracic operation. But have a look, if I'm standing up, I'm gowned and gloved. CMR actually working on a sterile sleeve for where I'm resting my elbows here. So I'll have my elbows rested, I'll be sterile, my gloves will be the only things getting desterilised, but I'll double glove. So if I need or want to come to the table, let's say I just want to do a staple firing that's a bit tricky, or let's say there's bleeding, or let's say I just want to change something to do with the arms that my assistant needs some help with. I literally take my outer glove off, go to the table, and then put some more gloves on before going back on the console. That's going to be a really, really good safety step. And I think really important and a real advantage of the CMR system. Other really nice things are it's a nice open platform. Other people can watch from your screen if you like. You don't have your head down a big, huge periscope. It's got nice little USB ports for your recording. And that's going to be really nice. Very soon, they are going to get into standard remote telementoring as well. They're going to put it on the CMR surgical system. Actually, every robotic company is rocketing their way towards this, the new technology, which is remote telementoring. So what am I showing you right now? Well, what I'm showing you right now is me remote telementoring the world's first thoracic surgery robotic CMR case from Chemnitz in East Germany. Obviously, we're in the height of COVID, so I couldn't travel out there. That was always going to be the plan, but it wasn't going to be possible. So we set up the React system. I've got 4 cameras. I've got one inside the chest, one outside the chest, looking at the patient, one looking at the surgeon's hand controls, and one that's kind of meant to be looking at him, although I seem to be looking at his groin in that shot. But so the really exciting thing is this is the whole new era of remote telementoring, and really it's only going to happen in robots, because robots are the ones that have got the funding, frankly. They're the ones that got the technology. They're already Wi-Fi enabled. They've already got the support from their reps. This isn't going to come to VATS. This is only going to come to robotics. So we did our very first cases. We've actually done 3 robotic CMR cases in Chemnitz, 2 wedge resections with lymphadenectomy and 1 thymectomy. Little warning, it's pretty scary doing remote telementoring. Your reps, your companies all say how wonderful it is. You can practice as many times as you like. But in the second case, the bespoke system went down. We had to hurriedly change to a Teams-based system. They set up 4 laptops. One of the reps was holding the laptop and over the patient so that the surgeon could see my face and I could see the ports. They pointed another laptop at the endoscope screen. It was all a little tricky. And then the Wi-Fi went down a little bit just when there was a bit of bleeding, so it was a bit scary. So for you surgeons out there thinking about receiving or giving remote telementoring, it is going to be very different. It's not going to be as good as being there. But actually, in addition to going to see people, maybe for the 4th, the 5th, the 7th case, or maybe in an urgent case where actually I have had one case where I was in clinic and they asked me to quickly go online to help out. That worked brilliantly. I just managed to hop on, give some advice, and then managed to get through the case. So this is a massive new era. And actually, more than the gadgets and gizmos in robotics, this is the exciting future of robotic surgery. A few tiny other little things just to show. There are new staplers out there in robotics, so you can use Covidian staplers, but the robot does have its own stapler, which is good. This is Sureform 45. It's getting better and better. But also there are smaller other staplers out there, and even in robotics, I'm now using the Covidian 8mm stapler for the really difficult, tricky vessels that the clunky staplers won't use. Just in case you haven't seen the 4th generation robot, here is the groovy robot, the 4th gen robot. So it's a great little system. It's really easy for your team to use. Of course, it's really important to note that it is a team sport, robotics. It isn't one surgeon. Your nurses need to be involved, your ODPs, your anaesthetists, but it makes your life so easy. There's amazing new little laser lines to help you dock exactly where you want. And then the vision's amazing. And it's just beautiful. It is the future of thoracic surgery. There's absolutely no doubt about that. Remember in 2012, we were at 5% VATS. We're now at over 50% VATS. I bet everybody, £50, everyone in the whole country, that in 5 years' time will be 50% robotic in the country. It's just going to happen. And it's just beautiful. It's just so easily set up. It does remote centering. So it sets up all the arms now for you. So it's setting it up automatically. So it makes it so easy to dock. Verb Surgical are actually working on a remote docking where you press a button and it comes and finds the ports. So all this just makes our life so easy. And that's the exciting future of robotics. We've got InDesign in green in robotics. So now we send people down to the CT scanner. They inject some InDesign in green, and you can see where the tiny nodule is. So the future is not lobectomy. The future is segmentectomy. At the AATS, the Japanese JCOG trial has just said segmentectomy has a superior survival to lobectomy for sub 2 centimeter nodules. So you cannot do lobectomy in below 2 centimeter nodules. But the robot allows you to do everything. You know where the nodule is, you know where the segmental plane is, makes it a piece of cake. It is just there to make your life easy. So what's the exciting future of robotics? We've just entered the Mastery trial. We're getting 500 cases in the country where it records absolutely every hand movement I do, or actually that Ben did, because Ben's done 12 robotic cases, and he's doing with me with our dual console in Middlesbrough, and it's recording how we do the operation. We get a quality of life questionnaire before at 30 days and 90 days, and so we're going to correlate how we do in the operation with how the patient does. So once we've got about 500 cases, we're going to know, and we're going to start metricing everybody's hand movements and give you a quality score of how well you've done your robotic surgical operation. And that opens up a massive and exciting future, because imagine you getting a score out of 25 for your robotics lobectomy. You got 24 out of 25. Imagine you're a trainee and you go to a job interview saying, I scored 24 out of 25 in my last 20 robotic lobectomies. Or imagine someone scoring 5 out of 25. That person needs proctoring or remote telementoring. So we are going to transform the safety of surgery. Have you ever seen a lobectomy go a little bit wonky, or some people not doing it the way you'd like to? This is all going to get found out in a good way, because we'll metric it. The people that are lower in the metrics will get more telementoring. The people at the top will learn from, because we'll see their videos, and that is such an exciting future. In that exciting future, every single robotic company realized this is the future. So CSATs, Orpheus and Touch Surgery are all 3 computer programs, all designed by Medtronic, Johnson & Johnson and Intuitive to do exactly what I've been describing. So they collect all the data. They segment up your videos into the specific moves. They tell you your timings, but more excitingly, they tell you how well you do. This will eventually all be done by AI completely. They're doing this already. They're going to do timing scores, but quality scores. And actually, they send your videos to mentors as well. And they'll describe what they think went good and bad in your operation. Then the AI is going to collect up all those keywords that say how well you've done and feed that back to you. So it's a really exciting future. CSATs already has 30,000 videos, most of them intuitive robotic operations, some of them laparoscopic. And you can actually look through this to learn better. But you can look at the ones that have got the highest scores. So because they're scoring all the videos, they're doing it by crowdsourced scoring, by 18-year-olds trained to do it. But that's an exciting future. So my time's nearly up. There's loads of other exciting things. We're doing pain monitoring. And we've actually got a massive, huge e-learning course in thoracic surgery, because we can't all go to courses anymore. So csuals.org, 40 different modules all about, it was set up for nurses, but actually it's great for registrars and anybody else, adjuvant therapy, cancer staging, cardiovascular management, chest drains, thoracic trauma, the works. So check that out if you like. So it's an exciting future. Thank you very much for listening, and hope you enjoy the rest of the conference.
Hello, everyone. Hope you all are well. Thanks to the organizers for inviting me for this presentation. I'm Sagar Haval, working with Getting A as a clinical application manager for perfusion and counterpulsation devices and therapies. I have my past clinical experience as a clinical perfusionist, ECMO specialist, ECMO coordinator, and a trainer. The topic of my presentation is ECMO in cardiac surgery, which is also called as post-cardiotomy extracorporeal life support, or PCECLS. At the end of the presentation, you will have an idea of what is ECMO. I would discuss indications, compare cannulation strategies, describe monitoring, explain possible complications, and discuss outcome data. ECMO or ECLS is used worldwide in various cardiac and/or respiratory indications. The recent biggest indication is the current pandemic, which has increased the usage of ECMO worldwide. Extracorporeal Life Support Organization monitors the ECMO or ECLS usage in its registry, and around 20,000 to 25,000 cases are performed every year. Around 492 centers participated in 2020 and reported around 16,605 ECMO cases. So post-cardiotomy extracorporeal life support in adult patients has been only rarely used, but recent data shows remarkable increase in its use, almost certainly due to improved technology, ease of management, growing familiarity with its capability, and decreased costs. Post-cardiotomy ECLS is proving to be a valuable resource for temporary cardiocirculatory and respiratory support in patients who would otherwise most likely to die. A large single center report demonstrated survival of around 25% to 42% with end organ injury and lactate levels as predictors of mortality. My journey with post-cardiotomy extracorporeal life support started 20 years ago. It was rough. It started from supporting patients with a huge heart lung machine and routine cardiopulmonary bypass roller pumps and circuit. Then later using specific components like centrifugal pumps and microporous oxygenators. Then I went into designing new circuits and designing new protocols to support post-cardiotomy ECMO patients. And then later, I've used various type of extracorporeal life support equipment in different locations of the hospital and sometimes out of the hospital situations. So a typical patient characteristic indicated for post-cardiotomy ECMO will include the patients could be relatively young. They could be they could have pre-operative renal insufficiency. They could be prior to they might have prior myocardial infarction or a left main disease or left ventricular dysfunction, or could have a coronary artery disease in the previous history, or maybe they could be post they could have a prior open heart surgery, and basically the patient's age represents a controversial aspect of post-cardiotomy extracorporeal life support. Several centers deny to start ECLS for patients above the cutoff age, whereas the majority regard older age as only relative contraindications. So the only absolute contraindications is uncontrollable bleeding. All other contraindications are relative, and the goals of treatment must be considered. So for patients in whom myocardial recovery is felt to be unlikely, ECLS should only be initiated if the patient appears to be a candidate for advanced cardiac therapy, like implantable ventricular assist device or heart transplantation. So the characteristic of the patients requiring post-cardiotomy extracorporeal life support in many instances differ from those of other potential recipients and clinical settings, all of which impact outcome. These patients are more complex than the conventional veno arterial ECLS cases. Their therapy support outcomes would be dependent on their pre-surgery cardiac condition, peri-surgery cardiac insult, that's during the surgery cardiac insult, post-surgery cardiac recovery, and insult from cardiopulmonary bypass and or other support devices. So what basically is ECMO? or ECLS. ECMO or ECLS can be defined as a bridge to treat patients with life-threatening, reversible or irreversible respiratory endocardiac failure. So this could be as a bridge to recovery, this could be used as a bridge to decision, bridge to bridge, or bridge to transplant. And it's been more than 40 years this technology has been applied and has been introduced, and there's been a change in clinical approach and technology. So ECMO or ECLS circuit is derived from the routine cardiopulmonary bypass circuit. A routine cardiopulmonary bypass circuit includes multiple components to support a stopped heart to aid in safe and effective surgery. Whereas ECLS constitutes minimal components designed for long-term use. So what we have here would be a return cannula. That's a venous cannula connected to the circuit, and the blood goes into a centrifugal pump, then the blood is pushed into an oxygenator, which also has a heat exchanger. Then the blood travels from oxygenator to into the patient, and the circuit is connected via an aortic cannula. So the main indications for ECMO or ECLS are severe hypoxemia, severe hypercapnia, cardiac arrest, cardiac failure, or unable to wean from cardiopulmonary bypass after cardiac surgery. This is post-cardiotomy ECMO or post-cardiotomy ECLS. So the application areas would vary and would be widely spread in the hospital. These indications could be found in multiple departments across the hospital. That's intensive care, emergency department, OR, cardiology. And if you look at the circuit configurations, there are main two types of circuit configurations. One could be a peripheral VA ECMO or VA ECLS, and there's another one called as central VA ECLS or ECMO. So the peripheral uses femoral artery and femoral vein mainly, and central uses the right atrium and ascending part of aorta directly. So it could be an open chest or it could be a closed chest, and the cannulae can come out via tunneling approach. We could also insert cannulae in this way, so we can go for a peripheral VA ECMO by using putting a venous cannula into the vein, femoral vein, but we can also utilize axillary artery for returning the oxygenated blood back. Then we could also tunnel the cannulae out after doing the central cannulation via the jugular tunneling or via intercostal spaces. Or we could also do a mixed cannulation. That means we can have a peripheral approach. So venous cannula put into the femoral vein, and then arterial cannula connected to a graft, and that graft could be possibly connected to a aortic graft if the aorta was changed, or directly to the aorta, and the cannula can be tunneled out that way. The graft can be tunneled out that way, and the cannula can be put inside the graft. But the most common, if you see, are peripheral veno-arterial using femoral approach, and that's the most common. And the other way of doing is central configuration. So what happens in the central configuration? We insert a cannula into the ascending part of aorta, and the blood flows antegradally to all the parts of the body. So this benefits in perfusing the coronary arteries with oxygenated blood, and this also benefits in perfusing the brain with oxygenated blood, and the flow is antegrade. Whereas in peripheral ECMO, the flow can be a little different. So when we put a cannula into the femoral artery, the femoral arterial or the cannular flow, blood flow would be happening retrogradely to the heart. So when the heart isn't ejecting, that time the coronary arteries and the brain would be getting the same oxygenated blood coming out of the oxygenator of the extracorporeal life support system. But when the heart starts ejecting, there happens a little bit of competition or afterload just after the heart. And if the heart is pumping deoxygenated blood, then the coronary arteries and the brain can get deoxygenated blood perfused into them. Also, what happens is when we put a large bore cannula into the femoral artery, the distal limb perfusion can be hampered or can be impaired. So for that, it is advisable to insert a distal limb perfusion cannula, which perfuses the limb and keeps the limb perfusion all right. So we have to be always mindful of the afterload, which is caused because of a femoral arterial cannula when we are inserting in. Then if the lungs are on lung ventilator settings, sometimes the ejected blood from the left ventricle will have the same saturation as the right atrium, and the coronary arteries and the brain can get perfused with the same saturated blood. Then we should prevent limb ischemia during ECMO by actively intervening, by putting a graft into side anastomosis and putting a cannula into that, or using a distal limb perfusion catheter. Then the arterial cannula is normally selected based on the blood flow rates we want to achieve. So the blood flow rates are calculated based on the cardiac index, what we want to achieve. And normally 2.4, 2.6 cardiac index multiplied by the body surface area would actually get you the blood flow rates to flow to the patient, inside the patient. And what we mainly target as an adequacy of perfusion indicator would be SpO2 of around 65 to 75%. And the lactate should be close to normal, then normal blood gases and normal urine output. We should also try to prevent Harlequin syndrome or the North-South syndrome, which I will cover in the next slides. And we should also vent the LV if required. And if the heart is not able to eject, we should always make sure that we are venting the LV. So there are few things which we monitor, especially on veno-arterial ECMO, is that we look at the adequacy of perfusion indicators, which are SpO2, we look at lactates, urine output, blood gases, and all that stuff. And we also look at anticoagulation and bleeding. We also make sure that the neurological status is all right, and we monitor that. And leg ischemia is another thing, and we should always try to prevent pulmonary edema, stagnation, or pulmonary clots during veno-arterial ECMO, and the ventilation is well managed. So what if you have a patient with stunned myocardium, where there is a risk of stagnation and thrombus in the LV, there's increased left ventricular end diastolic volume, and there's overdistension. This whole thing can impair the coronary perfusion and also lead to dilatation and regurgitation of atrioventricular valves. And this can also lead to pulmonary edema. So what do we do now in this situation if that happens? So there are various ways of performing ventricular venting. From my experience, the ideal way of venting is to keep the heart ejecting by using slight inotropes. But if you have a situation which doesn't allow to achieve cardiac ejections, then various tools could be used. The tools range from inserting an IVP or a cannula in the LV, or an impeller device in the aorta or pulmonary artery, or using transseptal suction devices like tandem heart. So what is Harlequin syndrome or the North-South syndrome? Let's have a look at a case scenario here. What if you have a case, have a patient which showed you SpO2 on the monitor, 68%. And when the blood gases were taken from the femoral artery line, or the post-oxygenator line, the PO2s were 33.3 kPa, PCO2s were 4.7, and SaO2s were 100%. So what's happening now in this situation? This could be because of a condition called as Harlequin syndrome. This mainly happens in femoral veno-arterial ECMO, and especially when the cardiac contractility has increased, and if the lung function is impaired or not ventilated, then the heart would be pumping deoxygenated blood out of the heart and causing a deoxygenated blood perfusion into the coronary arteries and the cerebral circulation. So this would lead to impaired coronary perfusion and cerebral circulation. So other complications are thrombosis, hemorrhage, limb ischemia, infection, and irreversible neurological sequelae. So if you look at the long-term survival outcomes, they range from 16.5 to 47.6%. And we could use different scores for prognostication before putting the patient on ECMO, like the Apache score, SAVE score, Remember score. The most useful ones are SAVE score, and also making sure that there's no end organ injury before putting the patient on ECMO or ECLS, and the lactates are not too high. So how do we improve the outcomes of veno-arterial ECMO? That could be done by training and development. So multidisciplinary teams have included perfusionists, registered nurses, respiratory therapists, intensivists, cardiac surgeons, surgical care practitioners, and formal identification of ECLS teams has improved survival in recent retrospective studies. In particular, a full-time intensivist team responsible for ECLS care appears to improve outcomes substantially. So here's my conclusion. Post-cardiotomy ECLS represents a valuable and undisputedly precious tool in cardiac surgery setting. Despite the enhanced technology of ECLS, related systems, and increased experience, several aspects still deserve further investigation and improvement. Configuration and timing of implant are particular aspects that have received attention and have changed in recent years. The characteristic of patients requiring post-cardiotomy ECLS in many instances differ from those other potential recipient and clinical settings, all of which impact outcome. These patients are more complex than the conventional veno-arterial cases. Their therapy support outcomes would be dependent on their pre-surgery cardiac condition, peri-surgery cardiac insult, post-surgery cardiac recovery, insult from cardiopulmonary bypass, and other support devices. Post-cardiotomy ECLS is proving to be a valuable resource for temporary cardiocirculatory and respiratory support in patients who would otherwise die. Thank you very much for listening.
Everybody could remember to vote on the poll, please. That would be excellent. And then in a few seconds' time, we will move on to the final presentation of the morning. So I'm in that slightly bizarre situation where the presenter that I have to introduce for the final presentation of the morning is in fact myself. So I'm a cardiac surgery trainee working in the Northwest in Manchester. And I've been asked to present on the role of additional imaging modalities in thoracic surgery. So throughout the whole session, we've heard about advancements in VAT surgery, advancements in robotic surgery, the use of mechanical circulatory support in cardiothoracic surgery, and now we're going to round it off by hearing about imaging. So the presentation that I'm going to be delivering is on the role of PET scan and MRI scan in thoracic surgery. Good morning, everybody. My name is Marcus Taylor, and I'm one of the cardiothoracic registrars working in Manchester. And I've been asked to talk to you this morning about the role of PET and MRI scanning in thoracic surgery. So in terms of what we'll talk about, we'll cover imaging in thoracic surgery, guidelines that underpin the role of imaging in thoracic surgery, and then have a look at the specifics of PET scanning and MRI scanning. So if we think about imaging in thoracic surgery in general, it's clear that imaging is a key component of thoracic surgery and underpins a huge amount of what we do. From a multimodal approach perspective, what I mean by that is that many different imaging modalities are used in different circumstances for different patients, for different pathologies, and at different parts of the treatment journey. These images range from things as basic as a plain chest x-ray all the way through to ultrasound scanning, CT, PET scans, and MRI scans. And again, as things continue to develop, we now have things like 3D reconstructions. And then you also have the combination of imaging with intervention, such as CT-guided biopsy, endobronchial ultrasound in combination with transbronchial needle aspiration as part of bronchoscopy, and even things beyond that, such as navigational bronchoscopy looking towards the future. But imaging is not just important at the time of operation, it's also important from a surveillance point of view. So patients with subsolid ground glass nodules, which haven't shown much growth, may have interval imaging. Obviously, one of the key components of imaging as part of preoperative workup to assess anatomical suitability of lesions to undergo surgery. And one of the main parts of imaging is to ensure that the imaging that you're looking at is contemporaneous, and that's particularly important for large tumours, aggressive tumours, central tumours, where scans that are even a few weeks out of date, when you then go on and get a new scan, things may have changed in terms of a tumour may now be inoperable if there's been some progression over the last few weeks of a central tumour and it's now invading a key mediastinal structure. We've mentioned that it can be used as an interventional adjunct, particularly for CT-guided biopsy, and also guidelines are now very clear on the use of imaging as part of post-operative follow-up, and that's particularly for patients who've had lung cancer resections as part of their post-treatment surveillance and survivorship programs. So as I said, there are a number of guidelines that underpin the use of imaging in thoracic surgery. We're going to focus specifically on guidance for lung cancer, and the two guidelines that are most prominent in this area are the British Thoracic Society guidelines from 2010 and the American College of Chest Physician guidelines from 2013. So the British Thoracic Society guidelines are on the radical management of patients with lung cancer and were published in Thorax back in 2010. And so essentially what I've done is I've picked out the key pieces of evidence, the key recommendations from these guidelines with regards to imaging and imaging modality. So the British Thoracic Society mentioned that you should view all available historical images and ensure that contemporaneous imaging is available at the time of treatment. And they've defined that to ensure that a CT scan should be less than 4 weeks old, particularly for patients with advanced or aggressive disease. The imaging modality that they recommend is a CT with contrast of the lower neck, chest and upper abdomen for all patients, with that being extended to additional areas of the body if there are any concerns about additional extrathoracic disease. And for all patients being considered for radical treatment, the BTS guidelines advocate that a PET should be performed as part of standard practice. With additional imaging of the head, they don't advocate MRI or CT. They say that both are reasonable, but they say that imaging of the head should be performed for advanced disease. If we compare that with the guidelines issued and published in the Chest Journal from the American College of Chest Physicians, slightly more recent in terms of their 2013 date. Again, the ACCP guidelines don't have quite as much to say on imaging as the British Thoracic Society guidelines. And again, these are relatively clear and unequivocal recommendations from the ACCP in terms of all patients should have a CT chest with contrast, all patients should have a PET scan, and all patients with advanced disease should have an MRI brain. And essentially that tends to refer to patients with advanced stage, so stage 3 or stage 4 disease, or a particularly large T stage, or particularly metabolically active tumours on PET scan. So if we then consider PET scanning, so PET stands for positron emission tomography, and this is a nuclear medicine scan with a particular fluorine radioisotope injected, and it's an 18 FDG fluorine radioisotope. But in other ways, it's performed in a broadly similar manner to a CT scan. You go through a scanner which performs the imaging, and you have an injection of the fluorine radioisotope as a contrast measure, And what that does is it provides a measure of glucose uptake. So once the FDG has been injected, what happens is the scan is then performed, and what you see on the scan pictures is anything that has high glucose uptake will shine. It shines brightly. And that's performed because it's indicative of metabolic activity. So if you think about aggressive tumor cells, they're constantly dividing and are therefore particularly metabolically active. And it's that metabolic activity that we want to capture with a PET scan to assess the likelihood of what we see on a CT scan as representing malignancy based on that metabolic activity. And so once you then see something where you're determining whether it shines brightly or not, and there are two ways in which you can then analyze the lesions. So you can analyze them subjectively, or you can analyze them objectively. So a subjective analysis of the lesion is essentially looking at how brightly it shines. And a lesion that shines particularly brightly is considered to be hot, whereas a lesion that doesn't shine up at all or has minimal uptake is considered to be cold. But clearly, as I've said, that's a very subjective analysis, and so the objective component of analysing the degree of metabolic activity on lesions for patients having undergone a PET scan is an SUV, and that stands for standardised uptake value, and what's reported is the maximum standardised uptake value. And what we know is the higher the SUV, the more likely the tumour is to be malignant, and the more likely the tumour is to be particularly aggressive. And then, so beyond the use of SUV in terms of confirming diagnosis, it's also linked to much longer term outcomes as well. And there's been a number of papers over the years that demonstrate that higher SUV values are associated with worse overall survival for patients with lung cancer, and that's patients with lung cancer undergoing all forms of treatment modality. And that's been looked at in a couple of different areas. So it's been looked at in terms of the SUV max of the tumour itself, and it's also been looked at in terms of the SUV max of any associated mediastinal lymph node metastasis. So patients with mediastinal lymphadenopathy, where on PET scan the mediastinal lymph nodes are hot, and on post-operative histological analysis the lymph nodes are found to have metastatic cancer deposits. The SUV value correlates with survival for both the mediastinal lymph node uptake and also for the uptake of the primary tumour itself. So the idea of a PET scan predominantly, the value of a PET scan is to provide some answers about diagnosis. So if you have a tumour on CT that then goes on to be cold on PET, then it's much less likely to be malignant. It's not completely excluded, which is why we don't rely on PET scanning in isolation for diagnosis. Most patients with a lesion on CT that either has suspicion of malignancy or has grown over time, even if the PET scan is cold, those patients will most likely still go on to have a biopsy, because you can't rely on the PET scan alone to exclude malignancy. Nevertheless, the mainstay of PET scanning is to look for mediastinal lymph node metastasis and to identify any suspicion about extrathoracic metastasis. When we look at its ability to evaluate the primary tumour within the thorax, it has limited anatomical resolution when performed in isolation, and therefore on its own it's not particularly useful for telling you things about anatomical location of a tumour in relation to other structures. However, as I've said, it's superior to CT for identifying mediastinal lymph node and extrathoracic metastasis, and inferior in terms of clarifying anatomical delineation. And that's particularly true for central tumours when you're trying to determine whether a tumour can be resected off the mediastinum, and for a peripheral tumour when you're trying to determine whether or not there's any chest wall involvement. So in terms of pathologies that have a high FDG uptake, so cancer So lung cancer as a term includes a wide range of pathology. You can have very, very small, slow-growing tumours which are not particularly metabolically active, which can be cold on PET that are still malignant. Equally, things like carcinoid, which again are very, very slow-growing malignancies, can often be cold on PET. And conversely, things like infection, inflammation, and infarction, although not malignant, can have a high degree of metabolic activity and can be hot on PET scan. And therefore, that's why we don't use PET scan on its own to determine whether or not a lesion represents malignancy or not. So it's a useful indicator, but it shouldn't be used in isolation and should always lead on to biopsy to confirm the presence or absence of malignancy. So if we then consider the role of PET in mediastinal lymph node metastasis, so CT and MRI scanning is the baseline imaging modality used to assess mediastinal lymph nodes, but their criteria for determining whether or not a lymph node is pathological is only morphological. And by that, what I mean is the only way that a CT scan has to evaluate whether they think a lymph node is abnormal is based on size criteria. And so the problem you have there is that you can have what we call reactive lymph nodes that have just grown in the presence of some pathology but don't necessarily have metastatic cancer in them. But also you can have normal sized lymph nodes which do have occult metastatic malignancy presence. And for that reason, CT scanning has poor sensitivity and acceptable specificity. So CT scanning will miss a number of positive lymph nodes by labeling them as negative, and that essentially is those nodes that are normal in size but have occult metastasis presence. However, if you then look at PET scanning, the specificity of the imaging is retained, but PET scanning has a much greater sensitivity. So PET scanning is a superior imaging modality in terms of sensitivity and specificity for recognizing metastatic mediastinal lymph node involvements. However, that being said, PET scanning isn't the universal panacea for mediastinal lymph node metastasis, and there are still up to a fifth of patients with normal sized nodes with occult metastasis who have a false negative PET scan. And so whilst that's not a great number, it is better than what CT scanning has to offer. And so just as PET scanning of the primary tumour isn't the only treatment that you perform to confirm diagnosis, the same is true in mediastinal lymph node involvement. And so in this era, a much greater number of patients will undergo EBUS, which is a bronchoscopic evaluation of endobronchial ultrasound and transbronchial needle aspiration, which provides an additional layer of assessment of mediastinal lymph nodes. And for those patients where either that's not appropriate or for other reasons, some patients may still undergo formal invasive mediastinoscopy, which, although invasive and not frequently performed these days, remains the gold standard approach to staging the mediastinum in terms of sensitivity and specificity. PET scanning is also effective at detecting extrathoracic metastasis, but there is one exception to this, and that is intracranial disease. So again, this harks back to the fact that PET scanning essentially looks at baseline metabolic activity. So the brain is a particularly active organ, and so there is frequent baseline cerebral metabolic activity. And so because of that, it's then very, very difficult for a PET scan to identify what is abnormal metabolic activity due to metastatic disease in comparison to what is baseline cerebral metabolic activity. And so these days, the imaging modality of choice to image the brain to exclude intracranial metastasis is an MRI scan. There are similar issues seen with adrenal pathology. Again, the adrenal glands are relatively metabolically active organs, and so it's not uncommon to have some degree of increased uptake in the adrenal glands. And what tends to happen there is either a dedicated chest radiologist will review the imaging and be relatively comfortable that what you're seeing is adrenal hyperplasia rather than malignant disease. But again, if there are any concerns, an MRI scan is performed to further delineate whether what you're seeing in the adrenal gland is incidental adenomas or highly suspicious of malignant pathology. In terms of the value of a PET scan at detecting extrathoracic metastasis, it detects unexpected extrathoracic metastatic disease in 10 to 20% of patients. And clearly the impact of that is that patients with metastatic disease have a profoundly different treatment plan and overall prognosis in comparison to their non-metastatic counterparts. And again, a PET scan is a very useful imaging modality, but is augmented by other imaging modalities such as MRI scans for the brain and things such as bone scans and MRI of the abdomen when uncertainty remains even after the PET scan has been performed. So as we've said, PET scans and CT scans in isolation have a number of drawbacks. And so in recent times, the combination of an integrated PET and CT scan performed in a single sitting has been advocated based on evidence that shows this integrated PET-CT scan is found to be a more valuable imaging modality compared to the sum of isolated PET and isolated CT. And it provides a precise correlation of CT images, which gives you the more precise anatomical delineation, in combination with the FDG uptake, which tells you more about extrathoracic disease and the extent and limits of metastatic disease and malignant disease within the thorax. And so for that, it's particularly useful to assess things like chest wall infiltration and peritumoral atelectasis, which the two imaging modalities in isolation are unable to perform at a high level. And so here we have some images. So as you can see, those things that are particularly metabolically active shine particularly brightly. That's where we talk about lesions being hot and cold. And again, you can see that the CT PET component gives you that combination of good anatomical delineation in combination with the FDG uptake. MRI scanning, there's very little to say about MRI scanning, but essentially is magnetic resonance imaging. It doesn't use standard CT contrast, it uses gadolinium contrast, and not all MRI scans require contrast. Obviously, there are drawbacks to MRI scan. Not everyone can go in there. If you've had a pacemaker or have other metal implants, it's not suitable for you. It's not routinely used for lung cancer work. It's not advocated in guidelines. But as we've touched upon, there's a role for MRI brain for advanced and aggressive disease, and there's also a role for MRI thorax for specific circumstances. So the MRI thorax is used for sort of superior sulcus tumours, such as thoracic inlets, Pancoast type of tumours, and that's because these tumours will often infiltrate things like pleura, endothoracic fascia, the brachial plexus, subclavian vessels. And MRI provides that superior soft tissue definition, which will determine whether or not offering surgery is appropriate and to help guide your operative strategy. The other role for MRI thorax is in tumours of the posterior mediastinum. So that's because posterior mediastinal tumours are usually neurogenic in origin, so neurofibromas, schwannomas, nerve sheath tumours, things like that. And it's extremely important before undertaking surgery to assess whether there's any spinal involvement of these tumours, whether they involve the foramina, whether they involve the canal or the cords. And for those instances where there is significant proximity to spinal structures, often these procedures are then combined procedures undertaken with spinal surgeons. And again, the mainstay of the MRI thorax in combination to a CT is the superior soft tissue definition provided that allows you to delineate these structures from each other. And you can see, unfortunately, I wasn't able to find particularly high quality images to illustrate this point, but you can see that when you put the CT scans alongside the MRI scans, particularly if you look at the bottom left, you can see there's a large posterior mediastinal mass seen on CT, and then the image to the right of it, the sagittal image, is the MRI scan. So you can see how at a greater depth you'd be able to see the soft tissue structures in much greater detail. So to conclude, imaging is a key component of thoracic surgery practice, and CT scanning is currently the standard baseline imaging modality used for thoracic surgery in terms of preoperative, perioperative and post-operative imaging. PET-CT is now routinely used an important part of lung cancer workup, whilst MRI is a valuable imaging modality, but is only appropriate in limited circumstances. Thank you very much. I'll be happy to take questions. Presentations that form this session. Again, I think everyone will be given a poll, so I'd be grateful if you could complete that for the organisers. And so now we've got 10 minutes left of the session where anyone is welcome to offer any questions or comments about what we've discussed over the last hour and a half. Let's see if there's any questions coming up in the chat.
While we're waiting to see if any questions do come in, I'd just like to apologise that Mr. Dunning can't join us for the Q&A today, but unfortunately he's found himself somewhere else to be this lunchtime. But obviously Marcus and I are here.
Yes, so I don't think any questions have come through so far, but if anybody has got any questions, if you type them, then they'll come through to us.
So Marcus, just while we're giving everyone else a bit of a chance to type, you've talked a little bit about the different imaging modalities and sometimes diagnostic uncertainty. What do you think about the role for the scoring systems, things like the Brock scoring system, the Herder system, for sort of integrating the different aspects from different imaging modalities?
It's difficult, isn't it? Because I think really as you know, on one hand, there's sort of studies to show that these are useful tools, but I think on the other hand, when you drill down to it, it's very difficult to get that sort of same degree of accuracy that you see for a population as a whole for each individual patient. And I think, again, for all of these tools, particularly from a radiological point of view, what you will always need is the specialist chest radiologist and to really sort of move these things forward.
I think they're always quite tempting. I think being able to produce a number sort of plays into our own cognitive biases as clinicians. I think we quite like being able to say, oh, this is the chance of it being a cancer. But then again, most patients seem to come out in that middle range between 10 and 70 where you're not sure what to do anyway.
And that's often the difficulty with these sort of systems, isn't it? Is that, you know, that you have very little degree of absolute certainty, and so more often than not, as you said, you're left in that middle ground where the uncertainty remains. And so from that point of view, the score perhaps hasn't moved you forward that much.
And I think looking at the recent lung cancer screening trial, they've relied quite heavily on volumetry and looking at volume doubling time to assess tumours, which seems, I think with modern PAC systems, that's getting easier and becoming more prevalent as well.
Yeah, absolutely. I agree.
So it's looking increasingly likely that no one out there has got any questions for us. So I suppose we should probably draw the session to a close.
Yeah, I think so. It's been an interesting session. Been some really nice presentations. We've sort of seen the full range of technological advancements in thoracic surgery, and have got a bit of a flavour as to where the future is in cardiothoracic surgery in general. So thanks everybody for joining us this morning. Hope you've enjoyed it, and we'll leave it there.
Good. Thank you very much. Enjoy the rest of the conference.
Thanks all. Bye bye.